Dr. Sirisha did her MBBS from Annamalai University, PG at Aravind Hospital, FRCS, and then she is a senior glaucoma consultant at LV Prasad Eye Institute, and she is doing phenomenal work in glaucoma. She has made a real difference to the way glaucoma is practiced and glaucoma is managed in our country. And she has won multiple video awards and multiple free paper awards. Welcome, Sirisha. Over to your talk.
Thank you, sir. Dr. Arup and Dr. Meena have been my teachers in Aravind Eye Hospital, and it's been a great pleasure and privilege to be here. So let's move to the talk. Angle closure and glaucoma and cataract. So why is this topic chosen? That's because I think there is a lot of importance that is given to cataract extraction in patients with angle closure. And 1/4 of the angle closure glaucomas are it's a majority of the glaucomas that we have, and majority of these angle closure glaucomas actually are in Asia. Apart from the conventional treatment of laser iridotomy, the medications and the glaucoma surgery, what we are trying to look at is, does lens have a role to play in these patients at all? What happens in angle closure glaucoma is basically there is a relative pupillary block. That is because of the iris and the lens contact, the fluid from the posterior chamber is not able to reach the anterior chamber, because of which there is angle closure and there is increase in the pressure inside the eye. Apart from that, there are two other mechanisms that I think we need to be very, very clear about that will help us to understand how and why we treat angle closure glaucoma patients differently. One is the very anteriorly placed ciliary processes that are there, which is contributing to plateau-iris syndrome. The other concept, which is kind of newer, but I think we've been intuitively knowing it and doing it for a very long time, that is a excess anterior vaulting of the lens. So does lens extraction have a role? Yes, it has, and it is definitely gaining popularity, either alone by doing a cataract extraction or with additional procedures like trabeculectomy, goniosynoculosis, or the endocycloplasty. How does it help? It helps by relieving the pupillary block and decreasing the posterior forces and crowding of the angle. So what do we understand from the published literature, and what is the role of each one of these surgeries in bringing down the intraocular pressure in patients with angle closure glaucoma? We know that just by convention, cataract surgery alone can bring down the intraocular pressure irrespective of which type of primary glaucoma it is, either it is primary open angle or angle closure or an NTG or a pseudoexfoliation. We know that in angle closure glaucomas, just because of the anatomy, the amount of intraocular pressure reduction is much, much higher compared to POAG. We also know that in patients with acute angle closure glaucoma, especially in the Chinese eyes and the Oriental eyes, where these eyes are very different, where acute angle closure glaucoma, despite a PI, despite peripheral iridoplasty, whatever you do, and medical treatment, the intraocular pressure is not going down. What next? So do you go and do a trab, or do you go and remove the lens, which is very huge in them, where people have tried removing the lens in them, whether it was cataractous or clear, and they found that the intraocular pressure reduction was quite significant. However, there were a lot of complications related to the shallow anterior chamber and the cornea. Excess anterior vault, when I say, is basically if you have vault, anterior vault of the lens, which is more than 1/3 the distance from the central corneal, that is back of the endothelium, until a line that is connecting the two scleral pulse of the temper and the nasal side. So if the vault is beyond 1/3 of this line, you call it as excess vaulting, and these patients significantly have an angle closure. That to a great extent is also dependent on the anterior chamber depth. If your AC depth is shallow to start with, even a minimal anterior vault could be much higher for that eye. So what happens in these eyes in angle closure glaucoma when you remove the lens? They have deepening of the anterior chamber just by replacing the natural lens, large lens with an artificial lens which is very thin. Also helps to open up the angle. So basically that mechanical push of the iris and the angle forward is kind of taken care of, and we know that there is very good evidence to say that it is very, very useful. How does it compare with the combined surgery? That means if you ask me the question, is cataract surgery better than combined surgery? I don't think so as far as the intraocular pressure control is concerned. The combined surgery has slightly better intraocular pressure control compared to cataract extraction alone. However, that comes along with the problems that we have with the combined surgery. How does it work in eyes with uncontrolled glaucoma? So if your intraocular pressure is very well controlled, you can go ahead and remove a cataract in a patient with an angle closure glaucoma. So could you do that in the presence of an uncontrolled glaucoma? People have tried it, and there is literature to say that it works, but definitely not as good as TRAB. So in patients with uncontrolled angle closure glaucoma or in uncontrolled intraocular pressures, trabeculectomy works better. The newer concepts that are coming up is, one of them is phacoendocycloplasty. So what you do here is you go ahead and do the regular cataract surgery. Once you finish that, like I said, in one of the conditions where there's a plateau iris syndrome, there is a very anteriorly placed ciliary process that pushes the peripheral iris forward. So at the end of the surgery, you go and try to ablate with a diode laser the posterior aspect as well as the anterior aspect of the ciliary processes, thereby shrink it. And while it shrinks, it just comes down and it pulls the peripheral iris downwards. So by doing so, you're trying to open up the angle. And these are some of the pictures which shows pre and post endocycloplasty, where you can see a wide opening of the angle with blunted ciliary processes. So the endocycloplasty and studies have compared with lens extraction, and in patients with severe plateau iris syndrome, where more than 3/4 of peripheral iris is occludable, lens extraction alone was insufficient in bringing down the intraocular pressure, and endocycloplasty did better. When they said did better, did it actually do so well? Actually not, because even with an ECP, the IOP was similar in the as it was in the preoperative, as is in the post-operative period, with a very modest decrease in the anti-glaucoma medication. So from 1.6 to 0.9, the anti-glaucoma medications came down by 0.5. So goniosyneculasis is one such procedure where you again do a regular cataract surgery, and then you go and try to remove the synechiae that is present in the angle. By mechanically removing it, you're thinking that you're opening up these trabecular channels, but we really don't know how well they work, and there's not enough evidence to say whether it is helpful or not. Another interesting thing that's come up is the clear lens extraction, and which is actually a lot of hue and cry about this, especially when the recent EAGLE study is published in Lancet. So clear lens extraction, we know that may not have a role in treating angle closure glaucoma patients, but then you have an evidence here which says that it is very, very useful and, compared to treating it conventionally. This was a large multicentric study that was done and recently published, where they looked at phakic eyes with clear lens in newly diagnosed primary angle closures as well as angle closure glaucoma patients, and they tried to do two types of procedures. One is the conventional laser PI and medical treatment. The second one is the clear lens extraction. And they interpreted that clear lens extraction showed greater efficacy and more cost-effective than laser peripheral iridotomy, and should be considered as a first-line treatment. I think this is going beyond what we actually can look at. Their primary outcome measures were looking at health-related quality of life and economic incremental cost for the quality of life, and clinical outcomes were intraocular pressures, which were very, very insignificantly different, of 1.18 millimeter difference between the two groups. And medications were different just by 0.3. And gonioscopy data in majority of these patients was missing, and they had a huge number of complications with the clear lens extraction in these eyes. So what do I take home from this study? I think it's very important. The reason why I quoted this study is because, first of all, if we take care of those patients who have cataracts, I think we'll be doing a good job. I don't think we should move to doing a clear lens extraction in these eyes, saying that this is going to be taking care of your angle closure for the rest of their life. So what do we look for? We look at the severity of glaucoma. You look for the amount of intraocular pressure control. Look for the number of anti-glaucoma medications patients are using. Look for their compliance. See how things are. Cataract surgery alone definitely works well, but you need to understand that early post-operative rise in intraocular pressure can be there, and we may need to continue the anti-glaucoma medications. Combined surgery definitely has a role, especially when the intraocular pressure control is not very good, or if the patient is allergic to medications or patient is non-compliant. Of course, the combined surgery is very, very useful, but we do face with problems related to trabeculectomy, but not so bad. If we can do a good surgery and follow them up very intensively, I think that will be all right. We need to understand these eyes are not without problems with corneal edema, corneal decompensation, malignant glaucoma, and all these problems. Definitely you don't want to go and intervene in these eyes if you think you can avoid it. So to summarize, cataract surgery definitely lowers the intraocular pressure in patients with angle closure glaucoma. I don't think at this point in time we have evidence which to say that clear lens extraction can replace anything that we are doing today. Combined surgery lowers IOP better than the cataract surgery alone. And when intraocular pressure control is a concern in these patients, I think beyond all these, trabeculectomy is definitely an option. Thank you.